Hi, my name is Purdey Macmillan, and I'll be presenting a case study about a previous client with post-traumatic stress disorder, PTSD. Also, the contextual factors that contribute to mental illness. Also, the mental health promotion services currently available in Australia for PTSD, pharmacological and non-pharmacological interventions, and a discussion on a mental health care plan. It is about a 29-year-old female who lives in a rural town of country Victoria. We will call her Julie. She lives alone and she's had a few relationships with women and identifies as a lesbian. Julie was diagnosed with depression in her 20s and has recently been diagnosed with PTSD by her GP due to trauma from childhood sexual abuse from a family friend when she was 9 years old. Growing up in a single-parent household, Julie and her brother were subject to physical violence from their mother, who was an alcoholic and suffered from depression, and didn't protect Julie from being abused by the family friend. She became an easy target for sexual violence as she got older because she would most often freeze and be too terrified to fight back. When her mother found out that Julie was gay, she was unsupportive and didn't approve of her sexuality. Julie quit her job because she saw a male who reminded her of the sexual abuser and subsequently left her workplace in a panic because she didn't feel safe. Julie has intrusive thoughts, panic attacks, and nightmares about her past abuse. As Julie has been feeling triggered, she feels that she can't return to her job. Julie had told her doctor that she would rather kill herself than return there. She began not feeling safe in her house at night, and the flashbacks and nightmares have become more frequent. She doesn't remember the details of her trauma, but only has images and feelings because her mind had wiped it out. She's having trouble sleeping and would become heightened and aggressive if anyone touched her head, especially near her face. Contextual factors include adverse life experiences, attachment style, poor parental mental health, living in rural or remote areas, experiencing abuse or violence as a child, and having a single parent. Studies have indicated that poor social support following traumatic events increases the risk of PTSD, and Julie explained that there was a lack of support from her mother and any other people in her life. Also, being a member of the LGBTQI community adds an additional risk of adversity and stresses that can contribute to developing PTSD during childhood, such as discrimination, bullying, and systemic discrimination. These are described as minority stresses in a theory discussed by Mayer and lead to higher rates of internalizing psychopathology, which includes depression, anxiety, self-harm, PTSD, and higher risk of externalizing behaviors such as substance abuse and suicide attempts. Mental health first aid is evidence-based and supports the recovery of PTSD and reduces the risk of suicide by providing social support by peers. Research by Dynenberg found that social support as part of a PTSD prevention program can be designed to help individuals at risk of developing PTSD and recovering from PTSD. Australia states that when medication is considered, the first choice would be selective serotonin reuptake inhibitors or serotonin non-adrenaline reuptake inhibitors. This is from the current evidence base for PTSD pharmacology as recommended by the American Psychological Association. Having medication would assist in Julie being able to manage and regulate her emotions and hyperarousal levels. These options would be discussed with Julie so that she can make informed decisions on her treatment plan when she sees her doctor. Phoenix Australia recommends offering psychological information on PTSD, emotional support and practical assistance consistent with the set of interventions collectively referred to as psychological first aid. For adults who develop PTSD, the best approach to psychological treatment involves confronting the memory of the traumatic event in order to come to terms with the experience. To measure progress, the PCL-5 is a 20-item self-report measure and can be used to measure the symptoms of PTSD. This can be done at Julie's first intake with the biopsychosocial assessment. The PCL-5 could then be repeated in 6 months to measure the changes in intensity of her symptoms. Before, I discussed the pharmacological interventions, but the non-pharmacological interventions include uh, trauma-focused cognitive behavioral therapy, cognitive processing therapy, cognitive therapy, and prolonged exposure, as well as EMDR, which is eye movement desensitization and reprocessing. Evidence suggests that social support from family has the potential to reduce the impacts of PTSD. However, Julie has no support from her mother, so no identification of other peer supports would assist her in her recovery, as people who lack family support should be considered as at high risk, an at-risk group, needing to be supported by services. Her intake assessment may reveal a need for additional psychosocial supports in areas of her life, so a referral to perhaps a social support program, employment services, and community or support groups based on Julie's needs, interests, and strengths. Identifying Julie's strengths and acknowledging her resilience while encouraging a perspective of hope and optimism is best to support Julie's recovery. A biopsychosocial assessment and mental state examination would explore Julie's background and history, including the contributing factors and impacts of trauma and her mental illness. However, a trauma-informed approach is crucial, especially if Julie talks about her childhood and the traumas she experienced. Adding an intersectional lens to assessment by acknowledging that minority stresses experienced by members of the LGBTQI community are often missed and would ensure that assessment is not only trauma-informed but trauma-specific. Not attending to any presence of shame due to her sexuality can weaken the impact of therapeutic interventions, as shame and homophobia are linked to internalized emotions. The Genderqueer Identity Scale includes questions that address minority stress in LGBTQI communities and can be included to assist in comprehensive assessment. Care plan is designed using evidence-based treatment options and trauma-informed assessment. It also considers the minority stresses that are unique to being a member of the LGBTQI community. There are no gaps in assessment to ensure that all factors and areas in Julie's life are addressed. By placing lots of supports and services in areas of need, assists in recovery and self-determination. I have expanded my knowledge by discovering the evidence on best practice and treatment for post-traumatic stress disorder. The recovery-oriented approach resonates with my values as a social worker, as I've always strived to empower clients to be informed and empowered and to be presented with many options and choices. The ethics of doing no harm, as always, are at the forefront of my mind, so being trauma-informed is crucial in supporting vulnerable minority groups. Allowing the person to be the driver in their recovery, I believe, is the best approach to recovering from trauma, especially sexual trauma where the power has been previously taken away. Supporting clients to build on their strengths can assist them to reach their potential while living with mental illness. Thank you for listening.